So next we have Dr. Nikita Pandey, and she will be presenting her paper on Sub400 protocol for corneal collagen cross-linking in advanced keratoconus, a pilot study.
Thank you, ma'am. Thank you for the opportunity. So I have no financial disclosure. So we all know that Dresden protocol has set a minimum corneal thickness limit of 400 microns for a safe cross-linking to be performed. This excludes many thin cornea, which may actually benefit from the treatment. So to overcome the limit, several modifications have been done in the recent past, which aim basically to modify the corneal thickness, either by changing the riboflavin concentration, or by placing a contact lens above the cornea, or by placing a smile lenticule, or by customizing the epithelial debridement. All these studies have been shown to give an inconsistent result in terms of reduced efficacy due to cross-linking. To overcome this disadvantage, Dr. Hafezi et al. Came up with a new protocol called Sub400 protocol, where he modified the UV fluence instead of modifying the corneal thickness. So what is Sub400 protocol? Basically, rather than changing the pachymetry, they kept the irradiation, the intensity of light same as 3 milliwatt per centimeter square, but changed the duration of irradiation according to the pachymetry to achieve the demarcation line at a fixed depth. This was the algorithm which was published by them only some 5 years back, and they used this algorithm in their study. So we aimed to evaluate this study in our Indian population. We conducted a prospective interventional pilot study for a duration of 1 year and included 15 eyes of 10 patients with progressive keratoconus. Progression was just defined as patients with primary ectasia in 10 to 20 years of age, or those who had increase in steepest keratometry by 1 diopter or manifest lenter by 1 diopter or spherical equivalent by 0.5 diopter in last 6 months. All these patients who had pachymetry less than 400 microns on corneal topography were included. We excluded those patients who were one-eyed, with severe corneal scarring, active keratitis or previous herpetic keratitis, any condition which interfered with epithelial healing, previous ocular trauma or surgery, pregnant lactating females, more than 10 pack years of smoking, or those who were unwilling for consent. Pre-interventional workup included BCVA in logMAR units, refraction both spherical and cylindrical, slit lamp evaluation for the diagnosis, corneal topography to record the thinnest corneal pachymetry, and keratometry at apex, baseline ASOCT, and specular microscopy to record endothelial cell density, which was not done in the previous study. So Sub400 protocol, basically, we removed the epithelium. Alcohol-assisted epithelialization, deepthelialization was done of 8.5 mm of the cornea, followed by soaking with 0.1% riboflavin in 1.1% HPMC for 30 minutes. After soaking, pachymetry was recorded. 10 such readings were taken, and thinnest pachymetry thus recorded was used to adjust the time duration of irradiation, and hence cross-linking was performed. Post-intervention evaluation included change in BCVA refraction, mean endothelial cell density, mean keratometry at apex, and mean thinnest pachymetry evaluation after 1 month, 3 months, and 6 months. Demarcation line depth from epithelium and its correlation with duration of irradiation was studied. Results showed most of the patients were less than 21 years of age. 4 out of 10 of them were males. Change in BCVA and change in refraction was found to be statistically insignificant after 6 months, but mean keratometry at apex changed significantly after 6 months. These are the few examples. And mean intraoperative minimum pachymetry ranged from 238 minimum to 395 micron maximum. This change again was significant at the end of 6 months. Fortunately, mean endothelial cell density did not change much at the end of 6 months, and insignificant correlation was found between mean ETD loss and thinnest intraoperative pachymetry at this 6 month. The mean demarcation line distance from endothelial range 6 to 94, and this correlation between DL depth and irradiation was found to be statistically significant. These are a few examples of the same. This is the graph showing the same correlation. We do have result after 1 year follow-up as well. So BCVA refraction and endothelial cell density did not change much after 6 months, but keratometry at apex and thinnest pachymetry did change significantly even after 1 year of follow-up. So out of 15 eyes, 15 eyes of 10 patients, 14 did not show any progression after 1 year of follow-up. And hence, we can conclude the Sub400 protocol is effective in halting progression in thin corneas of advanced keratoconus with a limitation of a smaller sample size and a shorter duration of follow-up. These are my references. Thank you.
How thin can you go when you're doing a sub 400?
Now, minimum that we did was 238 intraoperatively. That patient had 311 pachymetry on topography, ma'am.
And what are the effects on the endothelium, which you found in your
It was
sub
fine, ma'am.
400?
Endothelial cell density did not change, ma'am, significantly.
Yeah.
Ma'am,
Age.
age.
You can move forward, she can set up.
Ma'am, age as in family aplasia age group from 10 to 20 years. And after that, those who had shown progression over 6 months. Those who had shown progression over 6 months were included.
No, I didn't get you.
I mean, we included patients with progressive keratoconus. This included two groups, ma'am. Those who had primary ectasia in 10 to 20 years of age. Above 20 years of age, those who had shown progression over 6 months of period, like increase in steepest keratometry or increase in the cylindrical value by 1 diopter, we included those patients, ma'am.
That is the progression criteria.
Yes, ma'am.
So age by small children, will you
10 to 20
suggest
years.
10 to 20
Yes,
years,
ma'am.
not less than 10.
Not less than 10 years, ma'am.
How much was the sample? Your sample size?
It was a pilot study, sir. So we included 15 eyes. Now we have 38 patients with us
Right, a little bit inadequate at the time of presentation.
at the time of
Yeah.
research.
What is the kind of haze these patients developed? There was any haze?
No, sir, not marked haze. Minimal haze, sir. This one.
I think it would have been ideal if you would have compared this
Densitometry.
protocol with your riboflavin, hypotonic riboflavin.
Yes, sir, we are planning for that second.
It would have given
Yes, sir.
comparative results.
Actually, sir, the first study that was published by Dr. Hafezi et al. Did not include the safety margin. They had not tested whether cell density changes or not. So this was required to check the safety first. So when we have found that it's safe, we are on the way of checking with hypotonic as well.
All the cases you have done ACE OCT to check the
Yes.
demarcation line?
Yes, sir. For the study purpose, basically, to see. Yes. Thank you, sir.
Okay, thank you.